Echo-Doppler provided a tool which enabled a revolutionary improvement of the vascular pathophysiology, diagnosis, and treatment. Nevertheless, they are not yet sufficiently known and taught despite 120 articles, studies, trials, RCTs, Cochrane reviews, and 8 books. Definition of the venous function. There are 3 venous functions. The first one is the vital tissue drainage thanks to a transplantable pressure of the venous capillaries lower than the colloid osmotic gradient. 2. An adequate cardiac preload due to the reservoir effect, which is the variability of the venous volume to adapt pressures and flow to right ventricular preload needs. 3. Thermoregulation by superficial blood flow variation, radiator effect. Definition of the venous system. The venous system is the set of organs that interact to produce the pressures and flows necessary to the venous function. This system is made of 3 alternate mechanical pumps: right heart pump, thoraco-abdominal pump, valvomuscular pumps, and flexible and compliant tubes, which are venous capillaries, venules, and veins. Definition of venous insufficiency. Venous insufficiency is the inability of the venous system to provide all or part of the venous functions. Disruption of the reservoir effect. It's a drop of the cardiac preload due to too much venous blood stored in the lower limbs while too long-standing intravenous hemorrhage, or a cava vein block lying on the back in pregnant women. Dysfunction of the radiator effect by lack of superficial veins or low superficial venous flow. Tissue drainage dysfunction. Excessive transmural pressure by excessive intravenous pressure or low extravenous pressure. Practically, transmural pressure here is the only cause of edema, varices, traffic disorders, and ulcer. Intravenous pressure, IVP, is, according to Bernoulli, PS plus half rho V2 plus rho GH, where PS is a static pressure, half rho V2 is dynamic pressure, and rho GH is gravitational hydrostatic pressure. Gravitational hydrostatic pressure depends on the posture. Static pressure plus dynamic pressure is the motive pressure provided by residual pressure fed by the heart through the microcirculation, thoracoabdominal pressure provided by breathing movements, valvomuscular pressure provided by the valvomuscular pump when walking. Extravenous pressure, EVP, opposes the intravenous lateral pressure. It depends on the surrounding tissue pressure and the atmosphere pressure that decreases with altitude. The venous caliber depends on transmural pressure, compliance, viscoelasticity, and vasomotricity of the wall. Transmural pressure results from intravenous lateral pressure made of hydrostatic pressure, residual static pressure, and muscular pump static pressure. Opposition to the extravenous lateral pressure. Compliance is the wall capacity to increase with transmural pressure. Caliber increase with TMP and compliance. Compliance may be static or dynamic. Scholasticity. Fluidge is the caliber response to TMP, and relaxation is the vein capacity to keep its caliber when TMP decreases. Vasomotricity depends on the media thickness. Tissue drainage at the venous capillaries. The interstitial fluids of the tissues are drained into the venous capillaries when the colloid osmotic pressure gradient is greater than the transmural pressure TMP. The transmural pressure depends on gravitational hydrostatic pressure GHSP, on residual pressure and extravenous pressure. The gravitational hydrostatic pressure varies with the posture. The gravitational hydrostatic pressure varies with the posture at rest and decreases when walking, thanks to my proposed dynamic fractioning of gravitational hydrostatic pressure. When standing, valves keep open, so no gravitational hydrostatic pressure fractioning, valves open, no fractioning. But when walking, systole-diastolic alternate closure of the valves fractionates the gravitational hydrostatic pressure. Here, systolic distal valve closure, sys-level fractionation. Diastolic distal valve closure fractionation here. Gravitational hydrostatic pressure variation with the posture. Ankle pressure maximum standing at rest 90 millimeters. Pressure drops dramatically to 30 millimeters when walking due to dynamic fractioning of gravitational hydrostatic pressure. Then drops to 60 millimeters when sitting, 10 millimeters when lying down, negative when decline. Valve incompetence hampers the dynamic fractioning of the gravitational hydrostatic pressure when walking, but not at rest. Valve incompetence impairs the dynamic fractioning of the hydrostatic pressure when walking, but doesn't changing at rest, standing, sitting, lying, decline. Obstacle. to the flow increases both residual and valvomuscular pump pressures, explaining the claudication, the venous claudication when walking, and remains higher than normal in rest position, standing, sitting, lying, and decline. Residual pressure provided by the arterial pressure through the microcirculation increases with the resistance to the flow. When the obstacle is total, the flow is blocked and the pressure reaches the arterial value. Clinically, it is the phlegmasia cerulea. The venous stenosis are resistances that slow down the flow rate, increase the upstream and decrease the downstream pressure. The resistance obeys the Poiseuille law due to viscosity. Too many Nutcracker and May-Turner syndrome are over-treatments are due to venography and Doppler performed in an artifactual supine position, as I published in 2021. Pseudo-May-Turner syndrome. In horizontal supine position, echodoppler shows a left common iliac vein occlusion compressed by the right common iliac artery against the lumbar spine. Here, with the block dilated left iliac vein. In semi-seated position, spreads the right iliac artery and releases the flow, so no more May-Turner syndrome. Semi-seated here and the flow is free and normal on the left iliac vein. So it is not a true May-Turner syndrome. In 1988, I proposed a systematization of the venous networks, N1, N2, N3, N1 for the deep veins, the trunk of the saphenous and Giacomini veins in an aponeurotic duplication, here, aponeurotic duplication. 3 for the supraaponeurotic veins, and 3 here, supraaneurotic. And the physiological drainage hierarchy, and 3 and 2 and 1, and 2 and 1, and 3 and 1, and 2 and 1, and 3 and 2 and 1, and 3 and 1. Then I defined the pelvic escape points, the perineal escape point, clitoridian escape point, and inguinal escape point. Venous networks. Regardless of the direction of the flow, antigrade or reflux, the venous flows remain physiological if they do not reverse the drainage hierarchy. For example, Shiva does not ablate the reflex direction, but restores the physiological drainage hierarchy, which normalizes the flow rate and the pressure. In 1988, I described the veno-venous shunts responsible for the hierarchy reversal of the drainage. They are overloaded through escape points, N1 and 2, N2 and 3, N2 and 1, and drained back through the reentry points, N2 and 1, and 3 and 1, according to their anatomical configuration. This is escape point N1, N2, N2 and 3, and N1 and 3. In this example, this veno-venous closed shunt due to a valve incompetence of the great saphenous vein. Great saphenous vein is overloaded by the flow rate and pressure of the femoral vein during the diastole of the calf valvomuscular pump, which reverses the hierarchy through saphenofemoral escape point, EP, and redirects it back through the tibial reentry point, RP. Escape point, reentry point. During the diastole of the calf, the flow of the femoral vein is aspirated here through the escape point and the reentry point, escape point, reentry point, escape point, overloading the flow of the great saphenous vein. In this other example, this is a venovenous open vicarious shunt due to a femoral vein thrombosis. Great saphenous vein is overloaded by the flow rate and pressure of the popliteal vein during the systole or the calc pump, valvomuscular pump, which reverses the hierarchy through the tibial escape point EP and redirects back through the saphenofemoral reentry point. Thrombosis of the femoral vein. This is an escape point from the popliteal vein through a tibial perforator, for example, and that without any reversed direction, but direct direction, there is an overload of the great saphenous vein here with the reentry back in the common femoral vein. Various types of shunt are classified according to their escape points, reentry points, systolic and diastolic, and their activation by the Parana or Valsalva maneuver. This is various closed shunts from shunt 0 and various shunts of shunt 1, shunt 2, shunt 1 plus 2, shunt 3, various shunt 3, shunt 4, shunt 5, shunt 6, and mixed shunts. I don't describe precisely here. It will be described by the other lectures. The usual escape points are the saphenofemoral junction, the saphenopopliteal junction, pelvic escape points, 10 points, various perforators over here, and N2 and 3 junctions here, like here, like here, like here. I proposed Doppler reflex rate classification, and I called it the dynamic reflex index DRI, according to the reflex velocity mean, reflex time, systolic velocity mean, and systolic time. In this case, the dynamic reflex index is 0.125. Partial reflex due to just a leak here is a partial reflex 0.5. Segmental reflex here, just intermediate valve incompetence, value is 0.25. Total reflex here is all the valves are incompetent. Closed shunt, where the reflex is more important, the diastolic flow is more important than the systolic. The etiology of the venous insufficiency may be malformation, congenital, genetic, or biological, infection, phlebitis, inflammation, iatrogenic, especially responsible for varicose recurrence after varicose ablation, and venous hypertension by posture or obesity. They are responsible for venous system impairment, obstacle that increases the residual pressure, venous incompetence that increases gravitational hydrostatic pressure, shunts that provide maldistribution of the valvomuscular pump pressure, responsible for hemodynamic disorder by excess of transmural pressure that provides non-specific signs and symptoms. Drainage impairment causes edema, hypodermitis, and ulcer, and venous dilatation is the cause of varicose clinical veins. Edema, varices, trophic disorder, ulcer have one cause, an excess of transmural pressure. So whatever the clinical aspect of the patient, if the TMP is not excessive, the cause cannot be a venous insufficiency. So a good knowledge of the venous physiopathology, particularly hemodynamic, leads to physiological hemodynamic treatments. To say, lower the TMP according to the cause. Obstacles means liberation, stent, bypass, valve incompetence, valve repair, artificial valves someday, perhaps. Shiva strategy in any case, not only for superficial but also for deep venous insufficiency. In all cases, posture and compression. So any treatment that reduces the TMP excess is an hemodynamic treatment by intravenous pressure reduction like elevation and Shiva, or extravenous pressure reduction like compression. Any venous obstacle causes an excess of residual pressure responsible for all the signs of the venous insufficiency. Superficial veins ablation provide good immediate results, but mid-long-term damage as new compensatory varicose veins, matting, and spider veins. As it preserves the veins, so the draining flow, Shiva, prevents recurrence and drainage impairment, and at the same time saves the great venous vein for a potential need of vital arterial bypass. The cause of the venous ulcer is only the excess of transmural pressure at the level of the microcirculation. All the clinical signs are not cause but complications, inflammation, infection, necrosis. The proper treatment is reducing the transmural pressure by association of hemodynamic bandaging and antiseptic management. Hemodynamic is first of all 2 hours elevation with light elastic compression to deflate edema. Then take off the bandage and on the deflated leg, you just clean the debris and necrotic debris with water. No debridement is necessary if you use and apply Vaseline 40%, icing sugar 60% mixture, easy to do and very cheap, but more efficient than all others I used up to date. Then non-elastic bandaging, then distal arterial flow check with Doppler to avoid any excessive compression, ischemic compression. Repeat only once a week, bandaging and Vaseline sugar mixture. Conclusion. First, think TMP, whatever the signs, symptoms, and especially CIP. Then assess and treat hemodynamically the shunts respecting the drainage. Ablation is an irrational approach. It consists in vein ablation, phlebectomy, sclerosis, laser, radiofrequency, because it impairs the drainage and leads to residual pressure excess with tissue suffering, varicose recurrence, and destroys the venous capital. No more great saphenous vein for a vital arterial bypass. Instead of the hemodynamic approach, which is rational, consists in TMP reduction by extravenous pressure increase, leg compression, intravenous pressure decrease, feet elevation, block liberation, and Shiva, which is hydrostatic pressure fragmentation, shunt disconnection, drainage respect, and venous capital conservation. Thank you and congratulations for your patience.